Welcome back to part 2 of pharmacotherapies for Parkinson's disease. So far, we've gone through some parts of the introduction. We've did what is Parkinson's disease, what is the cause of Parkinson's disease, and what are the signs and symptoms of Parkinson's disease. We still have yet to go through treatment, research, and effect size. The research articles, and I'll conclude it with a final statement as well as the references. So treatment. Unfortunately, Parkinson's disease does not have a cure or any other treatment to slow the degenerative properties, but that does not mean that there are no other treatments for the symptoms. There are different classes of drugs. For example, there's dopamine replacement drugs like levodopa or carbidopa. There's dopamine agonists like pramipexole or ropinirole. There's catechol-methyltransferase inhibitors or COMT, such as entacapone and tolacapone. There's also monoamine oxidase beta inhibitors like selegiline and razagiline. There's anticholinergics like benzotropine and trihexylphenadiol. There's adamantadine, as well as others. So there is more and more research going into studying the effective treatment and the causation behind Parkinson's disease. Even though Parkinson's disease was diagnosed more than 200 years ago, we are only recently making advancements in understanding the disease. When considering research, you must also consider the effect size. Effect size can be considered as the actual effect between the measured groups, such as the experimental and the placebo group. Effect size is generally obtained by the results of the data analysis. It can be expressed as Cohen's d. For Cohen's d, a number that you get if it's 0.2, it's small. If it's 0.5, it's medium. If it's 0.8, it's a large effect. So generally, the larger the d-value, the less overlap there is between the two groups, and the more effective the drug is. Furthermore, there are also some standardized rating scales to clinically study Parkinson's disease. One that will be discussed is the Unified Parkinson's Disease Rating Scale, the UPDRS, which examines areas such as mental activity, behavior, mood, activities of daily life such as speaking, dressing, hygiene, walking, and so forth, as well as motor evaluation. There's also the Hoehn and Yahr, or the HY scale, that is used to describe how the symptoms progress. There's also the Parkinson's Neuropsychometric Dementia Assessment, or PANDA test, which evaluates cognitive function. So far there's 7. I have 7 research articles that kind of goes through some of the drug classes listed before, and we'll go through them sequentially. So the first one is therapies in Parkinson's disease. This paper is a review paper that examines the available drug therapies for Parkinson's disease. It uses evidence-based data to draw conclusions. Specifically, it covers drug therapies like monoamine oxidase type B inhibitors and dopamine agonists. But one thing to consider is that the authors of this paper were funded by pharmaceutical companies. So, monoamine oxidase type B inhibitors. In one study reviewed by this paper, it discusses the results of selegiline and levodopa. It was found that when in conjunction with levodopa, selegiline increased the activity of the drugs by about 9 months when compared with a placebo or tocopherol, which is vitamin E and an antioxidant. There was also an improvement in motor performance that was determined by a decrease in the UPDRS score. So in another study, they discussed the effects of razagiline and noted that as a monotherapy and as a conjunctive therapy, it is not very effective in treating symptoms, but it can increase neurotrophic factors. Neurotrophic factors are proteins that increase the survival, development, and function of neurons. Now, they also examined dopamine agonists, and they found that most dopamine agonists are effective in treating symptoms by themselves as a monotherapy, but they're not as effective as levodopa in treating the motor symptoms. The next article was differential effects of dopaminergic medication on basic motor performance and executive functions in Parkinson's disease. So in this experiment, it explains that Parkinson's patients compensate for the impairments by relying on external cues. This experiment involved Parkinson's patients as well as healthy controls that tested their motor reaction times. They used a dopaminergic medication for one trial and then another after a 12-hour withdrawal of medication for another trial, and this was done in a random order. They found that the Parkinson's patients scored lower on all tasks compared to the healthy controls, which means that the dopaminergic medication did not significantly improve reaction times or cognitive processes. But it was also found that the dopaminergic medication affects motor and cognitive performance differently in Parkinson's patients. So particularly, Parkinson's patients who stopped taking their medication for 12-hour withdrawal periods had a significant difference on the UPDRS scale compared to those who were taking their medications. Specifically, the withdrawal scored 28.4, while those who did not stop taking their medication scored 20.3. So the higher the score, the worse the symptoms. Now, one of the tests was a tapping frequency condition, and it was found that with external cues, 35.7% of the variance between the healthy controls and the Parkinson's patients was accounted for. So Cohen's D was given to be 1.492, so that means about 61.8% of the data did not overlap. For the internal cue condition of tapping frequency, 36.1% of the variance can be accounted for, and therefore the D is equal to about 1.5, which means about 70% of the data does not overlap. For the UPDRS, the internal acceleration, which is the faster internal response selection, 41.4% of the variance can be accounted for. Therefore, the D is equal to 1.683, which means that 73.1% of the data does not overlap. So for the Parkinson's Neuropsychometric Dementia Assessment Test, it was found for the external condition 23.7% of the variance is accounted for. Therefore, the D is equal to 1.115, which means that 58% of the data does not overlap. For the internal condition for PANDA, 35.9% of the variance can be accounted for, and therefore D equals 1.496, which means 68.1% of the data does not overlap. So when the data does not overlap, this means that the drug did have a significant effect on the Parkinson's patients compared to the other group, which in this case would be the healthy controls. Now, there were some problems with this experiment. Firstly, there was no real control. They compared the Parkinson's patients who had defects prior and who were already taking medication to people who did not have the disease and were not taking medication. It would be preferable if they compared the same group of individuals with and without the use of medication for all the tests. But once again, this can lead to practice effects. Also, the amounts of the medication were not controlled. It just stated what type of drug was taken for the test, which was usually the prescription of the patient as well as their usual dosage, so it was not a controlled amount or a controlled drug. And that is the end of part 2.